Good morning, ladies and gentlemen. Welcome to this session of dialogue and directions. This is being done to promote the guidelines, the recent International PCOS Guidelines 2023, which have been published in August 2023. And this is something which we are very keen to bring to the whole world and mainly to India, wherein we talk about various new aspects of the guidelines. Now, today we are going to discuss the role of anti-Mullerian hormone in PCOS. We all know that anti-Mullerian hormone is also called the Mullerian inhibiting substance. And this is something which was determined almost 20 years ago, and research is still ongoing. But yes, we have found that AMH has been very helpful to us in the mainly in talking about the ovarian reserve, talking about the number of follicles we see in the ovaries. We have talked about AMH to help us prevent hyperstimulation, and there are various other areas where it is being researched. And today we have one of the authorities in the world of PCOS, Professor Rob Norman, who is with us to speak to us on what is new about AMH and the guidelines 2023. I'd love to introduce Professor Rob Norman, who is a thorough gentleman and a wonderful person I know from across the world. Robert Norman holds the personal chair as Professor for Reproductive and Periconceptual Medicine at the University of Adelaide and is a subspecialist in reproductive medicine in endocrine biochemistry, FRCPA. He was the director of Robinson Research Institute at the University of Adelaide from 2008 to 2013, and he's had a collection of 60 research leaders in reproductive health and regenerative medicine along with him, with more than 450 members. As an editor, Professor Norman has been a leader of 2 NHMRC post-program grants, and that is the National Health Medical Research Center, and he has published over 450 peer-reviewed publications and 1 book. He has an H score of 108 on Google Scholar with more than 59,000 citations. Professor Norman serves on the editorial board of major reproductive journals. His major research contributions have been in IVF and reproductive endocrinology, particularly in the field of PCOS, the effect of lifestyle on reproductive outcomes, and periconceptual medicine. He's a former medical director and was an active reproductive endocrinologist with the specialist at the Fertility SA and was formerly CEO of ReproMed Private Limited. He has been the president of the Asia Pacific Initiative for Reproductive Society, and that is ASPIRE. He's been the scientific chair of ASPIRE and scientific chair of Fertility Society 2012 and currently. He was awarded an Order of Australia in 2013, and in 2015 he became a fellow of the Australian Academy of Health and Medical Sciences, and in the same year was awarded an Honorary Doctor of Medicine by the University of Adelaide. Professor Norman has been given the top award of the American Society of Reproductive Medicine, the European Society of Human Reproduction, and the Asia Pacific Initiative on Reproduction. He has been at the helm of affairs both in the 2018 and 2023 guidelines, and he's been conferred the Order of Australia, and he's been one of the well-known the leaders in the field of PCOS in Australia. Recognized for his work, he's been offered millions of dollars in grants towards all the research he does. He has published over 500 peer-reviewed papers, and he's been one of the only 3 gynacs who are fellows of the Australian Academy of Health and Medical Sciences. In 2015, he was awarded the Ricardo Aziz Award from the AEPCO Society. In 2017, he was made the life member of ASHRAE, and the 2018, the Lifetime Achievement Award of ASPIRE. And we are very happy to announce that we have confer the honorary membership to Professor Rob Norman for the PCOS Society of India, which he will receive during the annual conference of PCOS Society in June. Once we have the conference, it will be given to him during the inaugural function. So Professor Norman, I'm really delighted to have you, and since I know you so well personally, I think you're a great human being and you're the right person to speak on this particular topic. So over to you, Rob. Please go ahead with your presentation.
Dr. Shah, colleagues around the world, thank you so much for asking me to speak. It's a great honor to be part of this presentation. I want to just talk briefly about how AMH, which is a hormone that we're all used to using for IVF, is now part of our diagnosis and management in PCOS. And in my declarations, I have nothing that is relevant to this particular area. So let me remind you what we are now saying about the role of AMH when we diagnose PCOS. You will be well aware that we have to have 2 out of 3 criteria to make the diagnosis of PCOS, and polycystic ovary morphology on ultrasound is one of those. What we're doing now is we're adding AMH, and it's important to realize that you can use either AMH or ultrasound, but you can't use both to make up your 2 out of the 3. So the evidence-based guideline now says that AMH can be used for defining polycystic ovary morphology in adults, but we need to also be aware that it can't be used as a single test for PCOS. That is, if you've got a high AMH alone, that's not enough diagnosis to make PCOS. As with ultrasound, you can't use AMH in adolescents, and we recommend you wait for about 8 years after menarche before using AMH. So just to summarize, you can use either serum AMH or ultrasound to define the polycystic ovary morphology component of the diagnosis, but you can't use both to make up 2 components of the 2 out of the 3. So let's just talk briefly about AMH. AMH is a gene that is found on the short arm of chromosome 19. And through a series of processes, the messenger RNA is produced, and we have breakdown into a C-terminal and an N-terminal component. And this is where our antibodies that we use in our assays work. One antibody picks up an N-terminal and the other picks up a C-terminal. So the AMH precursor consists of an N and a C-terminal and 2 of them together, so they make a homodimer. And they then bind to a specific receptor, the AMH receptor 2. And this then is a surface receptor which then activates a series of pathways, which I won't go into detail today, in the target organ. It's important to recognize that the main target is in the ovary. However, when we look at the physiology of AMH, it's more complicated than we knew about 5 years ago. We can now pick up the AMH receptor in the breast, in the placenta, in the uterus, and it is influenced by fat and other substances. We also now know that the AMH receptor can be found in the hypothalamus and that it can regulate the control of LH. So a high AMH is classically found in polycystic ovary syndrome because of the numerous small follicles that are there. And it's classically low in premature ovarian insufficiency and menopause when follicles disappear. So in control women, AMH has relatively little effect on the hypothalamus, and that within the ovary, LH tends to suppress the AMH receptor and estrogen tends to suppress AMH production. Testosterone has little effect. However, if you have an anovulatory polycystic ovary syndrome situation, the LH is very high, and AMH, as a circulating hormone, interferes with the pulsatility of LH. The AMH receptor is also increased under the effect of high testosterone. So there is definitely a dysregulation of AMH in polycystic ovary syndrome. So when we look at what actually happens physiologically in the ovary, AMH inhibits the recruitment of primordial follicles, and it tends to stop the recruitment of large antral follicles. So most of its action is on primary follicles and preantral follicles. And this is why we've used it as a form of working out ovarian reserve. Now, one of the best studies that are available to us is one from Rotterdam, and many of the slides I'm going to show you are with the permission of Professor Job Belaven from Erasmus University. So they have published this wonderful study called Aphrodite in Fertility and Sterility in 2019. And they started off with patients that they had already discovered with PCOS. And they had a large number of controls in which they had eliminated the possibility of PCOS or any major endocrine abnormality. Out of these two groups, they had what was called a development cohort, where they tried to work out what the value of AMH would be in PCOS and in controls. And once they decided on that, they then got a new cohort, which they call a validation cohort, and that also consisted of PCOS and controls. And when you look at a histogram of PCOS versus controls using their data, it is very, very clear that control patients have a much lower AMH than patients who have PCOS. There's a considerable overlap, but at the same time, it's fairly obvious that there is a very big differential between patients with PCOS and controls. And when they took a cutoff of 3.2 nanograms per mil and applied this to a validation cohort, it appeared to be very similar. And so AMH is clearly differentiating to some degree between patients with PCOS and controls. So if you then go and look at the AMH concentration in PCOS versus control subjects in the development cohort and in the validation cohort, you will see that there is a very marked difference. And if you then control for age, looking at 25 to 35 years of age, the differential is even more marked. And as patients get older, this differential is also present. So this is an age-independent differentiation. However, as you'll know, AMH drops with age, and you can come up with a chart showing the different centiles for AMH dependent on age. And it correlates extremely well with the age dependency of the polycystic ovary follicles that are present. One can also, if you really want, come up with a chart that shows from the 5th to the 95th centile of values for AMH. And by and large, for PCOS diagnosis, we don't use this in great detail. And what I'm going to show you is that using a single cutoff clinically is probably the best way to go. It's important also to look at the different types of PCOS. I'm sure you'll all be aware that we've talked about A, B, C, and D phenotypes. And phenotype B is the one phenotype in which we don't define the polycystic ovaries on ultrasound. All the others use polycystic ovary ultrasound to make the subtype definition. And when we chart the AMH value dependent on the phenotype, we find that it's very similar between A, C, and D, but very much lower in B because there are no polycystic ovaries present. And when we take the phenotype A alone, which is the classical NIH, the severe PCOS type, and look against control, there's still a very marked difference. Now, it's also important to recognize that there are a number of other factors that alter AMH. So weight is one of them. So an underweight patient has a much lower AMH than an obese patient. But an obese patient also lowers the AMH. So when we look at cases or controls, being overweight lowers your AMH value. And this can be combined in a number of ways where we take into consideration the drop in AMH from BMI. A second important factor is if the patient is on the combined oral contraceptive pill, they have a lower AMH value for the same age. So we can chart those who are not on any birth control and those who are on combined oral contraceptive pill, and the latter have a much lower AMH. It's also important to note as well that the progesterone implant, such as a NOR implant, can have an effect on the AMH. So these things need to be taken into consideration. Nelson and his colleagues in Glasgow have done a wonderful job where they've looked at the effect of various factors on contraception on the AMH. And a copper IUD seems to have very little effect on the AMH value. A hormonal IUCD, such as Mirena, doesn't. But a progesterone-only pill, combined pill, a progesterone implant, and strangely, the vaginal ring also seem to lower AMH. And so these are factors that we need to consider when we're trying to work out a value. The other thing to note is that not all assays are the same. There are at least 4 assays that have been introduced, and you need to find out from your laboratory which one they're using. By and large, there are 3 current assays that are popular. There's the Beckman-Coulter, there's the Roche, and there's the PICO-AMH, and they come from a variety of different laboratories. The Gen 2 AMH and Alexis, the Roche and the Beckman use the same capture antibody and the same detector antibody. The PICO-AMH, the Anch labs, use different antibodies. When we compare these antibodies in the same patients, we see very good correlation. So if you see these lines shown in dark there, there's a very good correlation in terms of high values being high and low values being low. But if the assays were giving exactly the same results, they would follow the dotted line. And this is where there's identity in results. So a result of 40 on Alexis should read a 40 on the Gen 2. So we need to recognize that the absolute amount, the nanogram per mil amount, may be different between the assays, but a person who's high on one assay will be high on another assay. So you need to know your laboratory, and if you're going to remeasure the AMH, you need to make sure that you do it in the same laboratory, or at least with the same assay, rather than changing to a different assay. So what is the cutoff that we should use? Well, the Rotterdam group have given us excellent guidance. They've measured AMH using the Alexis AMH assay, and they included patients with clear PCOS phenotypes, aged 25 to 45. And they're recommending that we use 3.2 nanograms per mil, which is around about 23 picomoles per liter. And this receiver operating curves for this, looking at sensitivity and specificity, basically suggests that 3.2 is a good place for us to work. Remember that you get lower results with the pill, with high BMI, BRCA mutations, ovarian surgery, chemotherapy, and obviously as you get older. The formal data looking at sensitivity and specificity for the different phenotypes of PCOS is pretty good. It's well over 80% and close to 85%. So the AMH cutoff determines the prevalence. And Terry Peltonen and her colleagues in Finland have done a wonderful study looking at patients who are known to have PCOS by medical definition, and those who self-reported PCOS, who thought they had it. And if you took an AMH of 3.2 nanograms per mil as the cutoff, you would have a prevalence in the population of around about 14% with PCOS. If you took a higher cutoff of 5, the prevalence would drop to around about 10%. If you took a cutoff of around about 8, you drop down to about 7%. And if you took a cutoff of around about 10.3, your prevalence was 6%. So the prevalence in the population is going to change depending on what your cutoff is for AMH. If we're going to say 3.2, that gets very close to what we, with ultrasound, have used to diagnose the prevalence. So my conclusions are that AMH is now a useful alternative to ultrasound in assessing the prevalence of polycystic ovary morphology. And almost all of us have got access to AMH because we're using it for IVF treatment conditions. AMH assessment is of little value for the teenager. And so you need to use other criteria. And remember, you can't use ultrasound. AMH assessment is affected by a variety of factors, and you need to take a proper history when you're assessing the AMH. AMH assays are not the same between different commercial groups. So use the same lab and the same assay when you're going to do concurrent ones. And finally, until we get an international standard for consistency, we're still going to have discrepancies between laboratories and between assays. So you now have the choice of using ultrasound with follicles of greater than 20 per ovary, or you can use AMH. But remember, don't use both of them. In acknowledging my collaborators, I'm very indebted to Professor Joop Lauwen and his team at Rotterdam for their fantastic data, to the Centre for Research Excellence in Australia for their work, and for the funding that we've received. Thank you very much.
So thank you very much, Rob. Very, very clear information related to AMH in the diagnosis of PCOS, and it's various factors which affect it and which people do interpret sometimes incorrectly. So in short, I want to ask you a few questions related to AMH, which immediately strike me. I had a patient who came to me because somebody had told her that your AMH is very low and you need to go for egg donation. Now, unfortunately, AMH is a factor which is talking about the quantity of eggs, as I understand. The factors which affect it are use of contraception, etc., oral contraception. And I think that is a very important factor which we have to keep in mind, because many of our PCOS women have been on oral contraceptives for a long time. And then when they want to plan a pregnancy, they may find that their AMHs are low. So question is that how long one should wait for the oral contraceptive to be stopped before you can see the correct AMH value? Because there is a change with various factors. Say, as you mentioned, obesity, use of contraception, things like this. So if a woman loses weight, how soon we would expect her AMH to go up? Or if she stops the oral contraceptive, how soon would you recommend that we do our AMH levels? I think the message needs to go out to people as to when they should do it.
Duru, I think you can take one of two approaches. One approach, particularly for the contraceptive pill, is to say that we think the suppression is about 20% down. So you could mentally just say, I'll add another 20% onto the AMH, and that gives me a reasonable idea of where the woman sits. Now, that's obviously a calculated thing and not a physiological thing. If she's going to stop the contraceptive pill, probably you're going to want 6 weeks to 8 weeks at least to see a difference occurring, because that's how long it takes to get the hormones back to normal. With BMI, it's really hard to tell, and people take a long time to lose weight. So I think it's much more difficult in weight. But again, you could take the attitude of, if this woman gets back to a normal weight, her AMH is going to be 20% better now. But over 6 to 12 months, if she's losing weight, then obviously her AMH is going to go down anyway. So I think at the end of the day, it's just being wise.
Yeah, got it. So the next question to you is that we are talking about using AMH as a marker for antral follicle count instead of ultrasound if we do not have access to it. So does it mean that if a person has a high AMH, does it always mean that she has PCOS?
What it means is she has a very high probability of polycystic ovaries.
Yes.
And we know that that's very prevalent in the population. So high AMH tells us she's got polycystic ovaries. For those of us who do IVF, we know high risk of ovarian hyperstimulation syndrome. But by itself, it's not going to make the diagnosis of PCOS. So she's going to need to have either irregular cycles or hyperandrogenism to be converted from PCOM to PCOS.
Yes.
So I think we as gynecologists have been very casual in believing that just because a person's got polycystic ovaries on ultrasound, they've got PCOS. That's not true.
Yes.
And our endocrinology friends know that extremely well. They want to see hyperandrogenism or irregular cycles. So when it comes to teenagers, the recommendation of the guideline is forget about ultrasound, forget about AMH. You have irregular cycles and you've got hyperandrogenism. That probably makes PCOS. If you don't have all that, you can have a suspicion of PCOS, and then you wait until roughly the age of 20 to do ultrasound or AMH.
Right. So that's what we have to mention, is that if there are, if it's a high AMH or if it is a number of follicles on ultrasound are increased, we would call it polycystic ovarian morphology and not really PCOS. Unless it is this morphology is associated with hyperandrogenemia or follicular.
That's correct.
This is making it clear. My next question to you is that when we have women with high AMH, sometimes we find that it's difficult to induce them. They don't respond very well, and it takes a long time for them to respond to that stimulation. So what could the reason be for that, and how should we manage those patients? There are some centers, I realize, that when the patient has a high AMH, if they don't find a response to a few days of gonadotropin, they immediately step up the dose and then finally end up in hyperstimulation. So what would you recommend as to in women with high AMH, say with an AMH above 10? What would you recommend to those patients? I
think this is a challenge, and I remember very clearly a patient I had who was normal weight, but a very high AMH. And I couldn't get her to ovulate on orals. And I started on low-dose gonadotrophin, and I couldn't get an ovulation. And I ultimately went up to 300 units of gonadotrophins, and we even struggled to get one egg then. So we don't really understand why that's happening, apart from the fact that for oral ovulation induction, we think the AMH is circulating, it's working on the hypothalamus, it's probably inhibiting pulsatile secretion of LH. And so there's a reason, a hypothalamic pituitary reason for orals not to work. However, you'd expect gonadotrophins to work. So obviously the very high AMH in the ovary is also inhibiting recruitment of good antral follicles. One of the things we put in the guideline for fertility treatment is laparoscopic ovarian surgery. And I know a lot of us don't use it anymore, but there may well be a case in these circumstances where you have somebody who has a very, very high AMH and you can't get anything to work, to consider doing either ovarian drilling or, although this is not very popular, removing a small part of the ovary to try and drop the AMH value. So that would be all I could suggest, Duru. There'll be lots of your listeners who've got much more experience than maybe I've got in that area. But I'm always very nervous when I see a patient with an exceptionally high AMH. I know I've got trouble ahead.
Yes, absolutely. But you mentioned that AMH is measured with different assays, gives you different results. There's no international sort of space in which we could compare. So suppose I have a patient who's come to me with an AMH done in a particular lab with a particular assay as say 8, and then she comes back after a few months with an AMH from a different lab with a different assay as 8. I understand we prefer to do the assays in the same lab, but the question is sometimes patients, especially in the private sector, tend to go where they are comfortable. So how would we compare such results? Should we repeat the test, or should we have a way of determining what really is the correct answer?
I think one thing that you could do is if you get an AMH from another provider, from another doctor or another city, it might be worth getting your secretarial staff to phone on your behalf, to phone the laboratory in that city and say, could you tell us what assay you use? Mm-hmm. So if the assay is the same as the assay that your laboratory uses, then I think you could be reasonably happy to compare them without repeating them. But if you can't get that information, or it's coming from a laboratory that's completely different, even though AMH is a very expensive assay for the patient, it's a lot cheaper than you starting off on the wrong treatment. So probably it's wise to repeat it in your laboratory just to be sure, rather than to have the patient pay a much higher amount of money for a treatment that may not be appropriate for them.
Okay, got it. So in short, you would say that. And then we have another situation where women have their AMH done in any part of the cycle, whenever they find it convenient. Is it necessary to do it at any particular time? Would it matter so much?
There doesn't seem to be a lot of problem with doing it at any stage of the cycle. It's nice to have it in an ovulatory follicular phase of the cycle, but I don't think it really matters whenever it happens. AMH doesn't seem to vary a lot during the cycle, and certainly not as lot as the other parameters that we've been talking about.
Right. So I think it's okay if you have a result done in any part of the cycle, and you may not repeat it if it's done with the same assay. Is that what is clear? So question to you also is that we do find ethnicity affecting the PCOS phenotypes of our patients. different phenotypes have and different ethnicities have different presentations. So does it also happen with AMH that you see it different in different ethnicities?
There was a nice paper in Human Reproduction this year looking at East Asians across a number of countries from East Asia, which suggested that the AMH is probably slightly lower in patients from Chinese, Japanese, Korean background. I'm not really aware of the data on Indians, although I'm pretty sure that it would exist from countries such as the UK. So it's probably worth us checking up on particularly people from Indian subcontinent and how they relate to the published Caucasian values. But certainly for people from East Asia, we tend to think the cutoff might be a little bit lower.
Mm-hmm. There is a little bit of a, sort of a disconnect with AMH values according to the guidelines, talking about anything about 3.2 could be diagnostic of a PCOM. But there have been data from other studies where they say 4.6 or 4.7 is supposed to be the cutoff for PCOS. So now that the difference being, I suppose, that 3.2 is for PCOM and 4.6 is for PCOS. Is that what it means?
Yes, I think when we looked at the evidence for the guidelines, we were not happy to recommend any value of AMH for diagnosis of PCOS. Now, clearly, if you took 10 as a value, almost everybody over 10 is going to have PCOS.
Yes.
But what we're looking for is a practical guide for clinicians to substitute for ultrasound. And something like 3.2 using that particular assay is okay. But I think it's got to be worked out for each laboratory, each assay, and each ethnic community.
So this particular 3.2 was with what assay was done to give a level of 3.2? Have you got that information?
My recollection was that that was the Roche assay, and I will check that up with you. But the automated assays are the ones that most people are using because they're the same machinery that you use for measuring FSH, LH, estradiol, progesterone, all the hormones that gynecologists are used to.
What about the PICO AMH?
So the PICO AMH is produced by Ansch Labs, which is a very high quality laboratory. The founder is very, very committed to quality. I'm not aware whether that's automated at the moment, but I suspect it will. If it's not now, it is already. Sorry, if it's not already, it will be.
Okay, all right. I have a last question for you is that there have been some research studies talking about AMH being associated with either metabolic syndrome or being associated with hyperandrogenemia. Is there any thoughts on that? Because we've been talking in the field of fertility, IVF, etc. This is going a little beyond it.
We do know that hyperandrogenemia promotes the AMH receptor and AMH production. So if you've got hyperandrogenemia in the ovary, you probably are going to have much higher levels of AMH. The metabolic syndrome, obviously there is a relationship with fat, but I suspect that most people who have a high AMH have a high androgen, and that's also associated with hyperlipidemias.
Okay. But with a high BMI, you had mentioned that the AMH would be lower.
Yes, it does tend to be lower. I don't think anyone's really sure of why that happens. But we know, for instance, when you stimulate the ovary with orals or with gonadotrophins, you get a lesser response with a high BMI. So that may be correlated together.
Okay. There has been some Indian data talking about PCOS and genital tuberculosis being associated. So
that would be interesting. Yeah.
Yes, so there is some information on that, but I'm not sure whether it's been found in many studies. I'm not sure about that, but there has been a reference to it. Do you have
anything that destroys the ovary or infiltrates the ovary would reduce the number of follicles and therefore the number of AMH molecules being produced. So it sounds logical.
Absolutely. The last question to you, Rob, is that there are young women today we find who have got a low AMH, low AMH and less number of eggs in their ovaries. And all their investigations have been showing that there's no issue with them in terms of even the history. There's no history of smoking, there's no history of surgery on the ovaries, there's no maternal early menopause. There's nothing in their stories which will tell you why the follicles are less. Even young girls at 28 and 30 having it. Any thoughts on that?
Well, we know that a low AMH is correlated with a low number of follicles.
Yes.
And there's been some wonderful work done in Europe in particular, looking at genetic causes of early menopause and of low follicles. And it would appear that there's no one specific gene that is responsible for that. And in fact, the Rotterdam group, who are really good at this, have suggested that disease or longevity genes are altered in patients with low ovarian follicles. So when they looked at patients who had premature ovarian insufficiency with low AMH, they found that they had a much higher prevalence of genes that were associated with early death and with aging. So I think the ovary is just a window to the world of what's coming in the future. And it's the same as with pregnancy. We know that complications in pregnancy, such as hypertension and diabetes, are predictors of what may happen later. And I think seeing low AMH and low ovarian insufficiency is correlated to some extent to future health and longevity. Having said that, we need to remind people, which obviously you, Duru, know very well, is that age is the most important thing when it comes to fertility. So having a low AMH at a young age still is highly correlated with good chance of getting pregnant.
Yes. Thank you very much, Professor Rob. It's been a great pleasure talking to you, and thank you very much for sharing your thoughts and your wonderful presentation and your expertise with all of us. Thank you so much.
Thank you, Duru. It's always a pleasure. Thank you.
Thank you.